Welcome back to Pathways in Pediatrics. This is the podcast of the European Academy of Pediatric Societies, EAPS.
We're continuing our look at some of the most popular sessions from EAPS 2025.
That's right. And today we're really digging into a session that generated a lot of buzz. Novelties in bronchiolitis. It was a crucial disease-specific panel.
It really was. What made it stand out, I think, was bringing together experts from such different angles. You had intensive care, pulmonology, and infectious disease prevention all represented.
Right, with Dr. Rebecca Ting, Dr. Valentina Fadi, and Dr. Anoni Sono-Arand presenting.
Exactly. And the focus wasn't just academic debate. It was about giving us practical, actionable insights, trying to get that full 360-degree view.
So that's our mission for this episode, to cut through the complexities and highlight what really felt new and important from that session at the Congress.
And I think we have to start where Dr. Ting started, with the critical care side, the PICU management.
Yeah, and the kind of paradox she presented, you've got these big evidence-based guidelines like AAP 2015, NICE 2020.
Right, and they're pretty clear, but mostly about what not to do.
Exactly. No proven benefit for beta agonists, corticosteroids, hypertonic saline, even chest physio in severe bronchiolitis. The evidence just isn't there.
But then, the reality on the ground. Dr. Ting shared survey data showing lots of clinicians, especially intensivists dealing with the sickest kids, are still using some of these things.
It's almost like a clinical pushback. I was really struck by that data from the London hospital she mentioned. Nebulizer use actually went up after the NICE guidelines specifically said not to use them.
It suggests clinicians really struggle with being told, essentially, there's nothing much specific you can do, that feeling of needing to intervene.
But we have to follow the evidence. And she presented more strong data, didn't she, from that UK trial on surfactant?
Oh, yes, a really high-quality study. Blinded, 232 babies. Quite definitive.
Surfactant has always been this sort of lingering hope for the really sick, ventilated infants.
Well, this trial pretty conclusively showed it makes no difference. Not for the main outcomes, not for the secondary ones either. For critically ill ventilated infants with bronchiolitis, surfactant is another thing we can confidently say doesn't help.
So if these specific add-on therapies aren't the answer, the focus has to shift, right, towards just standardizing the basics of care.
Precisely. And this is where the Congress really shone a light on some, frankly, startling variations in practice between different centers.
Startling is the right word. The data Dr. Ting presented from observational work in London and then the bigger UK national study, it was kind of shocking.
It really was. I mean, you're talking fundamental things. Nasal tubes for feeding, used in 99% of babies in one PICU, and only, 2.9% in another?
That's incredible. And sedation too, midazolam, used in 94% in one place and none at all in another.
It makes you wonder how we can even compare outcomes or talk about best practice when the baseline care is so vastly different. It's like they're treating different conditions sometimes.
It really underscores the importance of standardization, doesn't it? Which leads to the findings on protocolized care.
Yes, that secondary analysis of the Sandwich trial was key. It showed that having nurse-led protocolized sedation, along with weaning and extubation readiness testing, well, it significantly cut down the time kids spent on mechanical ventilation.
So standardizing the process, empowering nurses, that makes a difference.
Definitely. And linked to that, the UK national study had an interesting finding about which sedative might be better, though it's retrospective data, we should note.
Ah, yes. What did that suggest?
It hinted that using an alpha agonist, like dexmedetomidine, instead of a benzodiazepine like midazolam, was the only factor linked to getting kids extubated sooner.
Interesting. Needs more research, obviously, prospective trials. But it's a strong clue that what we use for sedation, not just how we wean it, could be really important.
Absolutely. One more point from the ICU perspective before we move on, the fear around bacterial co-detection.
Right, the Bacon study. The assumption has always been, find bacteria on the endotracheal tube aspirate, and the outcome's going to be worse.
Exactly. But this study looked at hundreds of kids and found, well, something quite counterintuitive. Yes, 55% had bacterial growth initially, but that co-detection was not associated with worse outcomes. In fact, there was even a suggestion that maybe those kids had a shorter time on the ventilator.
Shorter? How could that be?
Well, the thinking presented was, maybe if there is a bacterial co-infection that's contributing, it's actually more readily treatable with antibiotics than the underlying RSV illness just running its course. So perhaps they recover a bit quicker from that treatable component.
Fascinating. It definitely challenges that knee-jerk reaction that bacterial presence automatically means trouble.
It does. Okay, so let's shift focus a bit, away from the ventilator, towards that middle ground of respiratory support. non-invasive options.
Yeah. High flow nasal cannula, HFNC. For a while, it felt like the answer was just started early for anyone needing more than basic oxygen.
That early enthusiasm has definitely been tempered now. We saw data converging from 4 big randomized controlled trials, FU, Paris, Bronch, PathOI, and the Dutch trial.
And they all compared starting HFNC early versus standard low flow oxygen first.
Right. And the overall message was, well, early HFNC probably isn't the magic bullet we hoped for in terms of reducing hospital stay or escalation.
I remember the Paris trial result was quite striking. Treatment failure rates were different. But paradoxically, more kids ended up needing ICU transfer in the group that got high flow early.
It's a crucial point. If you start with your main escalation therapy right away and the child still worsens, you've kind of run out of road before intubation.
And didn't the Paris 2 trial in slightly older kids also show something similar?
Yes, in 1 to 4-year-olds, starting high flow early was actually linked to a longer hospital stay.
So the consensus message from the session for managing kids on the ward or in the emergency department is shifting back a bit.
It seems so. The takeaway was that starting everyone on standard low-flow oxygen and only escalating to HFNC if they really need it is probably the most sensible and likely the most cost-effective approach.
Makes sense. Keep your escalation options open.
Exactly. And there was mention of ongoing UK trials looking at other potential steps, like maybe higher flow oxygen via face mask as a cheaper intermediate step, or comparing CPAP versus high flow on the wards, so the story isn't totally finished there.
Okay. Now let's pivot completely, away from the acute illness and towards the long-term consequences. Dr. Valentina Fadi's presentation really brought this home.
It really did. Focusing on the pulmonology side, the shadow that an early life RSV infection can cast, we're talking huge numbers globally, 12 million lower respiratory tract infection episodes every year.
And the impact doesn't just stop when the child leaves hospital.
Not at all. Dr. Fadi highlighted data showing kids who have an RSV LRTI early are at much higher risk of getting recurrent chest infections later, even non-RSV ones. One South African study showed a 3-fold higher risk.
And the link with wheeze and asthma later in childhood, that's pretty well established now, isn't it?
Oh, yes. The classic Tucson cohort study was mentioned a 4-fold higher risk of asthma or wheezing by age 6 if you had RSV in the first 3 years.
4-fold. And that persists.
It seems to. Data from Sweden showed that among kids hospitalized for RSV as infants, the asthma prevalence was 39% by the time they were 18. Compare that to just 9% in their peers who weren't hospitalized.
Wow. But it's not just about symptoms like wheeze, is it? It's about actual changes in the lungs.
That was a really powerful part of the presentation, the impact on lung function trajectory. Early RSV infection is linked to measurable deficits, lower FEV1, signs of small airway obstruction.
And those deficits stick around.
Critically, yes. The data suggests that lower lung function established in childhood tends to track right through life. They even cited studies showing low values persisting into adulthood, potentially up to age 70.
That completely reframes the importance of prevention, doesn't it? It's not just about avoiding a week in hospital.
Absolutely.
Yeah.
It's potentially about preserving lifelong respiratory health. Dr. Fadi shared a striking finding. Just managing to avoid RSV infection in infancy was linked to a 25% lower risk of having asthma at age 5.
And that Italian study during the COVID-19 lockdown, that was almost like a real-world experiment.
Phenomenal, wasn't it? A 44% drop in wheezing episodes in children born during lockdown, and it seemed directly tied to the massive reduction in RSV circulation at that time.
It really drives home the impact of exposure.
It does, and it opens up future possibilities too. If RSV triggers this long-term inflammation, maybe following a specific immune pathway like the Th2 response with IL-5 and IL-13,
Yeah.
could we intervene?
You mean like with biologics?
Potentially.
Yeah.
If we could block those pathways, maybe we could modify the long-term disease course after infection. It's speculative, but an exciting thought.
That sense of urgency, the need to prevent these long-term issues, sets the stage perfectly for the final part of the session. Dr. Anoni Sono-Oran talking about prevention.
Yes, moving from managing the consequences to stopping the infection in the first place. And we finally have some really powerful new tools.
Game changers, really. Maternal vaccination and nirsevimab.
Exactly. The single-dose, long-acting monoclonal antibody. The efficacy data presented at the Congress was really impressive.
What were the key numbers again?
For maternal vaccination, efficacy was around 68% against severe disease at 90 days post-birth, dipping a bit to about 57% by 180 days. Still significant protection.
And nirsevimab.
even higher in places that got really good coverage, like over 90%. The Catalan data showed around 76% effectiveness against needing medical care for RSV and about 80% effectiveness against hospital admission.
Those are fantastic numbers, but there was always that nagging question, are we just delaying severe infections?
That was the crucial follow-up data presented from Spain, from Galicia, and Catalonia, where they had that high nirsevimab coverage.
And the answer was?
Reassuringly, no. They found no compensatory increase in severe RSV outcomes in the following season among slightly older children.
That is huge. It means these interventions seem to provide real, lasting public health benefit, not just kicking the can down the road.
Absolutely. It confirms the potential. However, Dr. Ariane was also very clear about the challenges. The science is strong, but getting it implemented is another story.
Yeah, the hurdles are significant. It's not just about convincing people, it's practical access.
Right. We saw in the UK, for example, that relatively low uptake of maternal vaccination limited its overall impact. But the really big issue is cost and availability, especially in low and middle-income countries.
Which is where the death rate from RSV is tragically highest.
Precisely. And even in wealthier countries, there are equity issues. Reaching vulnerable groups like migrant pregnant women who might miss the optimal window for maternal vaccination. That's a real challenge for achieving the kind of population coverage needed.
So it's been quite a journey through this session. We started with the slightly chaotic picture in the ICU, the practice variation despite guidelines.
Moved through the debates on respiratory support, the sobering long-term lung health consequences highlighted by Dr. Feedy.
And landed on these potentially revolutionary prevention strategies discussed by Dr. Arand.
I think the real novelty, the core shift highlighted at EAPS 2025, is moving away from arguing about whether ineffective treatments work,
towards actually having tools that can prevent a huge amount of this disease, both acute and long-term, from happening at all.
It's a fundamental change in perspective.
So here's maybe a final thought for you, the listener, to ponder. If these prevention strategies, maternal vaccination and nirsevimab, continue to prove highly effective and become widely adopted, what happens next?
What will that remaining group of children who still get critically unwell with bronchiolitis look like? Will the main virus causing severe disease shift away from RSV towards, say, rhinovirus or others?
And will our current management protocols, developed primarily in the RSV era, even be the right ones for that future population?
A really interesting question. Something for future EAPS congresses to undoubtedly grapple with.
Indeed. Well, thank you for joining us for this episode of Pathways in Pediatrics.
We hope you found it insightful.
We wish you well. And please remember, if you were registered for EAPS 2025, you can still log into the virtual Congress platform to watch the recording of the Novelties and Bronchiolitis session, and indeed all the other fantastic content.
Definitely worth revisiting. Until next time.